Hi friends, today we're going to talk about bacterial meningitis. And if you like this video, make sure to give it a thumbs up and subscribe to my channel. I make new nursing content every week for nurses, nursing students, and pre-nursing students to support you in your nursing journey. Also, make sure to check out all the free resources I have down below, as well as the NCLEX and pharmacology study guides. All right, let's get into it. So meningitis is an inflammation of the lining around the brain and spinal cord caused by a bacteria or a virus. Bacterial meningitis is caused by bacteria specifically, and meningitis can be the primary reason a patient is hospitalized, or it can develop during a hospitalization. So the pathophysiology of bacterial meningitis is first the transmission of the bacteria concentrates in the nasopharyngeal and is transmitted by secretions or areola. Oh my God, I can't fucking talk and read. All right. So first is transmission. The bacteria enters, oh my God, I really can't talk. All right, this is the last one I'm doing. So with the pathophysiology, first is the transmission. So the bacteria enters the lungs, and one of the causative organisms then will enter the bloodstream, and it will cross the blood-brain barrier and proliferate in the cerebrospinal fluid. And there's then stimulation. So the host immune system stimulates the release of cell wall fragments and lipopolysaccharides, which facilitates inflammation of the subancrinoid and pia mater. So that's in the brain. It's causing inflammation in the brain, which is going to increase intracranial pressure because there really is not a lot of room for expansion in the brain. And then the cerebrospinal fluid circulates through the subarachnoid space. So that's again in the brain, where inflammatory cellular materials from the affected meningeal tissue enters and accumulates. So let's go into this in a little bit more detail. So as you know, and if you've seen my other videos, I love these charts because it puts everything on a nice one-page summary. So we can see the blue is the pathophysiology. So we have our bacterial meningitis, which is a bacterial infection of the meninges. And that's going to lead to different mechanisms, including infection-induced systemic inflammatory response, which is going to increase the body's basal metabolic rate. So we'll see fever and tachycardia. The inflammation near the brain will interfere with normal central nervous system functioning. So we're going to see an altered mental status. The best way to test this is something called the Glasgow Coma Scale. It would be less than 14. We'll see lethargy, stupor, confusion, delirium, and coma. Visual pathways become sensitized to light and pain due to inflamed meninges. So we'll see photophobia. We'll also see meningeal irritation will stimulate dural neuroreceptors around the brainstem and neck, and around the spinal cord. So we'll see headaches, stiff neck pain, sore back. It'll also lead to cranial nerves exiting the central nervous system through inflamed meninges, can be irritating themselves, so that can lead to cranial nerve palsies. So meningeal irritation detected by certain physical exam maneuvers. So we can use hip flexion while patient is supine. We'll go over this a little later. And passive neck flexion. These will stretch the lumbar skeletal meninges, irritate the which irritates nerve root, and inadvertently knee flexors, and you'll see hamstring contraction and decreased knee extension. This is known as Koenig's sign. We'll go over this in another slide. And then the passive neck flexion, which stretches the lumbar sacral meninges, irritates and excites the nerve roots, inadvertently hip knee flexors, and these muscles contract, and we'll see spontaneous hip knee flexion, which will be Brudzinski's sign. And again, we'll go over this in another slide. And lastly, meningococcus also infects blood vessels, endothelium, and lower limbs, resulting in an immune response, creates a vasculitis that causes local clotting abnormalities. So we may see petechiae or purpuric rash, especially in lower limbs, and this can lead to limb ischemia. So causes of bacterial meningitis can include tobacco use, which predisposes the patient to meningitis, a upper respiratory infection. So if it's a viral infection, it's going to be just regular meningitis. If it's a bacterial infection, it can be bacterial meningitis. Otis media increases the risk of bacterial meningitis because the bacteria can cross the epithelial membrane and enter the subarachnoid space. If the patient has an immune system deficiency, it puts them at a greater risk of developing bacterial meningitis. And typically the bacteria that we'll see with this in 80% of cases is Streptococcus pneumoniae and Neisseria meningitidis, as well as Haemophilus influenza in children. So clinical manifestations that we'll see include a headache. It's usually steady or throbbing and very severe as a result of the meningeal irritation. Neck mobility, so these patients will have a stiff and painful neck. This can be an early sign. Any attempts of flexion of the head or neck can be very difficult. We'll see that positive Kernig sign. So this is when the patient is lying with the thighs flexed on the abdomen and the leg cannot be completely extended. We'll see positive Brudzinski's sign when the patient's neck is flexed. Flexion of the knees and hips is produced. When the lower extremity of one side is passively flexed, a similar movement is seen on the opposite. We'll see photophobia, so extreme sensitivity to light. Skin lesions from a petechiae rash with purpuric lesions to large areas of ecchymosis. We'll see cognitive impairments. They can be disoriented, have memory impairments. These are usually early signs. They can even lead to seizures as a result of irritability of the brain. So here is an example of the Brudzinski's sign and the Kernig sign. So the Kernig sign, we can see if a knee is flexed at 90 degrees, so that's here, and hip is flexed at 90 degrees, then extension of the knee is painful or limited in extension. So it looks pain or limited extension. So if we try to straighten out this leg, it's going to hurt and it's going to be difficult to do. Brudzinski's sign is passive flexion of the neck. So if they're laying down and we lift up their head, their legs are going to flex. So their hips and knees are going to flex. So if they're laying completely straight and we lift the head, the knees are also going to come up. So prevention. So one of the preventions is a vaccine. There is a meningococcal conjugated vaccine given to adolescents during high school and college freshmen in dormitories. We can also offer health education about meningitis. There's also antimicrobial prophylaxis, so people in close contact with patients with meningococcal meningitis should be treated with antimicrobial chemoprophylaxis using rifampin, ciprofloxacin, or ceftriaxone sodium. So complications we can see from this are visual impairments. Infection may spread towards the eyes if left untreated. It can also lead to deafness because it can reach the optic nerve, and it can lead to seizures because it irritates the meningeal layers. So assessment and diagnostic findings, we can do a CT scan or MRI to detect a shift in brain contents prior to a lumbar puncture. A key diagnostic test is a bacterial culture and gram staining of cerebral spinal fluid and blood. And diagnosis is made by a lumbar puncture. So if the cerebral spinal fluid is cloudy, so normally cerebral spinal fluid is cloudy, a gram stain of the cerebral spinal fluid reveals organisms in 70 to 80% of all cases. And when organisms cannot be identified, bacterial antigens can be determined. Usually H. influenzae is frequently detected with this technique, and Clients with bacterial meningitis usually demonstrate a moderately elevated cerebral spinal fluid pressure, elevated cerebral spinal fluid protein levels, so the normal amount is 15 to 45. Decreased cerebral spinal fluid glucose levels, so normal is 60 to 80. Elevated white blood cell count usually increases 100 to 10,000 with predominantly polymorph nuclear leukocytes. And a medical diagnosis is made by assessment of the clinical findings and is confirmed by isolating the causative organism from the cerebral spinal fluid. So medical management is going to include antibiotics are usually given by IV, and adequate fluid and electrolyte balance must be maintained with frequent assessments of neurostatus to detect early manifestations of increased intracranial pressure and seizures. Anticonvulsants may be prescribed for seizure prevention. Antibiotic therapy, so antibiotics that cross the blood-brain barrier specifically are needed, which can halt the multiplication of bacteria. So something like vancomycin might be used intravenously. There's also corticosteroids like dexamethasone, which has been beneficial as an adjunct therapy in the treatment of bacterial meningitis if it is administered 15 to 20 minutes before the first dose of antibiotic and every 6 hours for the next 4 days. And fluid volume expanders may be used for dehydration and shock. So our nursing assessment should really be focused on neurological status. Again, that brain is inflamed. We're going to see those neurosigns, and we're going to have to create precautions or procedures or interventions to help with those. You also want to be looking at the pulse ox and arterial blood gas values to identify if there's any need for respiratory support. So our nursing diagnosis can include things like risk for infection transmission related to contagious nature of organism, acute pain related to headache, fever, neck pain secondary to meningeal irritation, acute pain related to nuchal rigidity, muscle aches, immobility, and increased sensitivity to external stimulus secondary to infectious process, impaired physical mobility related to intravenous infusion, nuchal rigidity and restraining devices, activity tolerance related to fatigue and malaise secondary to infection, risk for impaired skin integrity related to immobility, dehydration, and diaphoresis, risk for injury related to restlessness and disorientation secondary to meningeal irritation, and interrupted family processes related to critical value of situations and uncertain prognosis. We can also have anxiety related to treatment and risk of death, and risk for ineffective therapeutic regime management. So our planning and goals, we want to protect against injury, prevent infection, restore normal cognitive functions, and prevent other complications. So our interventions can include things like assessing the neurological status and vital signs constantly. We want to determine oxygenation from arterial blood values and pulse ox. We want to insert a cuffed endotracheal tube or tracheostomy and position patient on mechanical ventilation as prescribed. This again is going to depend if there's any respiratory issues going on. Assess blood pressure, usually monitored through an arterial line for shock. We want to use rapid IV fluid replacement as prescribed, but take care not to overhydrate the patient because we can risk cerebral edema. We want to reduce high fevers to decrease the load on the heart and the brain from oxygen demands. We want to protect the patient from injury, specifically related to seizure activity or altered level of consciousness. We want to monitor daily weights, serum electrolytes, urine volume, specific gravity, osmolality, especially if syndrome of inappropriate antidiuretic hormone is suspected. We want to prevent complications associated with immobility, such as pressure ulcers and pneumonia. And we want to institute infectious control precautions until 24 hours after initiating antibiotic therapy. And we want to inform the patients and their families of their conditions and permit family to see the patient at appropriate intervals. So our evaluation, again, is going to depend on our patient outcomes, but it could be things like avoidance of injury, avoidance of infection, restoration of normal cognitive function, and prevention of complications. Our discharge and home care guidelines will include activities, alternating rest and activity to conserve energy, providing a diet with healthy foods, using asepsis to promote reduction in infection, and educating on infectious processes, so identifying signs and symptoms of infection, process and report to physician properly. And our documentations will include client's description and response to pain, acceptable level of pain, prior med use, current physical findings, client's understanding of individual risks and safety concerns, availability and use of resources, current and previous level of functioning, effects on independence and lifestyle, results of labs and diagnostic tests, mental status, cognitive evaluation results, plan of care, teaching plan, response to interventions, teaching and actions performed, attainment of progress towards desired outcomes, and modifications to the plan. So I hope you guys liked this video. If you did, make sure to give it a thumbs up and subscribe down below. Also check out all those free resources I have for you, as well as the NCLEX and pharmacology study guide. I'll see you next time. Bye.